So sufficiency of tissue is a big issue. So I was at a meeting the other day, and for one clinical trial, the group wanted 40 sections from a core biopsy, and I'm like, come on. And if we sent all that out, we wouldn't have the tissue to do the things we need for immediate patient care, EGFR, ALK, ROS1, RET, PD-L1. So it's definitely a problem, and it definitely is going to require multiplexing, prioritization, no matter what. So I turn to David to tell me how to handle that.
So the amount of tissue is critical. In fact, as the biopsies are small, we can make nucleic acids from them, but if we make nucleic acids, we can't test for PD-L1, and we can't test for other markers that say whether it's an adenocarcinoma or a squamous cell. So you have to sort of triage the amount of tissue you get. Now, hopefully we get more, but if a clinical trial is requiring 40 sections, that completely exhausts the tissue. So we can't really do that because that's, we have to do all the standard of care tests first, and then we can have the rest of the tissue go off to a clinical trial. How many sections do we get on an average time? We might only get 20 sections from a standard biopsy, and then it's gone. And not only that, but we're required as a pathology lab to keep some diagnostic material. We can't send it all out. Liquid biopsies are interesting because they allow you to get not only more tissue because you just draw another blood draw, but you can get it at multiple time points. The problem with liquid biopsies is there's hardly anything there. It's kind of like looking at smoke instead of fire. And so sometimes the smoke tells you what's going on, but not always. And sometimes you need more. So, interesting studies are now going on to try to really evaluate the value of liquid biopsy. There are in some targeted therapies, there's already clear use for liquid biopsies. And even in the 18 recommendations from our societies, it's recommended, in the recommendations are use of liquid biopsy when you can't acquire tissue. So already that's happening. But will it give us the sensitivity and specificity we need? Those trials still need to be done, and I'm a little concerned that the smoke won't tell us that. We'll need a little fire.
Yeah, on our lung cancer master protocol, we're obtaining liquid biopsies now. This is a large public-private partnership where we're screening many patients around the country for biomarkers and then assigning them to different arms based on those markers. So we'll hopefully have some correlation between the tissue biopsy and the liquid biopsy. I use a liquid biopsy in the clinic. When I want something quickly, it can be done in real time. If it's negative, though, you still need to go to the tissue. But if you do targeted liquid biopsies, they can come back very quickly. And very often, when someone has a disease such as EGFR mutated disease that's recurrent, there aren't easy sites to biopsy. What if it's in the bone or something like that? So liquid biopsies can be very useful, and they are going to be the future. And the technology keeps getting better every year.
And the liquid biopsies can be better if you if you know what gene you're looking for. So in the case of recurrence, we're looking for just a handful of genes and trying to do whole exome sequencing, which you can't do yet, or even doing TMB or something like that from liquid biopsies is a lot more challenging than looking for just an EGFR, just mutations, and there's only maybe 7 or 12 mutations that we'd look for by liquid biopsy. And that can be done. There are companies developing tests to allow us to turn that around in 24 hours. So that's a real service to our oncologist colleagues.